Very good morning to all the participants of this webinar. I'm really happy to see all of you really coming forward to attend our webinars. Before we proceed, I just want to say a few lines about our educational trust. The dawn of August 15, 1974 was an auspicious day for MNR. This day, the trust was born, and this day saw the forming of MNR Educational Trust, founded by Sri M.N. Raju Garu. He is the man behind this MNR Educational Trust. His hard work, perseverance, and his vision led the institution to this present stage. Our campus in Sangareddy is a beautiful campus with lush green campus. And we can say that it's a modern Takshashila in imparting the quality of education. Our Vice Chairman, Sri M.S. Revivoma Sir, is a live wire of our campus. He imparts enthusiasm into the young and old. We are really happy to be part of this great family of MNR. And coming to today's speaker, Miss Betsy George, I'm really happy to inform you all that she is a student, a graduate of our BSc Nursing, first batch, that is 2003 batch. As a student, I have found her a very enthusiastic, energetic, very brave girl, and taking a lot of leadership in all her activities. Being the first batch, they had to undergo a lot of hardships, but they have helped in each moment of our college. And I am really remembering all those days with real happiness and gratitude. It's my pleasant privilege to have her in this platform. She works right now in UK, and I have seen her resume, and within the short span of her career, she has achieved a lot of things, and she has come up to this level, and I'm sure it is a motivation for our students who are studying in our college right now. I'm sure many of her batchmates, her juniors will be watching this, and wish you all students all the very best wherever you are. And at present, Betsy works in this Worthing Hospital, and with 12 years of her experience, she's mainly working with our respiratory team. And Betsy, I'm really happy, and I welcome you all, and welcome you especially. And it's my pleasant privilege to have you here, and all the very best.
You can unmute me.
Should we go?
Yeah.
Good morning, all. Thank you very much, Shobna ma'am, for your kind words. I firstly like to thank the management at MNR College of Nursing, Chairman, Vice Chairman, sir, and Shobna ma'am for giving me this opportunity, actually remembering me after so many years. On behalf of my batchmates and myself, actually, the years that we have spent at MNR was this, what do you say, the foundation stone for us. That's made us to achieve, to be brave, to excellent whatever areas we have been. Thank you for remembering again and inviting me to this live webinar. Welcome to everybody who are participating here. What are we going to speak today is the actual route of nursing, the prime route of nursing. Through the 4 or 3 years of our nursing education, we learn so much. And the outside world expects us as nurses to know the answer for everything from headache to heart attack. They think we know the answer for everything, but it only comes with experience. And one such thing that we will need on a forefront of our nursing experience is basic life support, that is BLS. So what we learn from our books or the procedures that we do through our 4 years of nursing is very different when you actually go in a live scenario or when you're on your wards. And one such thing, again, I would say is basic life support. So today's topic that we will be discussing, hopefully for an hour, is BLS, or adult basic life support. Now I'm going to share, hopefully we won't have any, technical glitches. I'm going to go ahead and share the PPT with all of you. Once we have the PPT on and running, I hope you can see the PPT, or I hope everybody can see the PPT all right. So we're going to learn today for an hour about basic life support. Generally, this should be done in a, in a lab room where you have the mannequins. But unfortunately, in the current scenario, we don't have the mannequin, we don't have a lab room. What we're trying to achieve in the next 1 hour is giving you an insight of my experience with basic life support, how basic life support works in the country that I am working in. I work in United Kingdoms, England. So here, how do we carry forward with basic life support? That's what I'm going to explain to you. It could be different to some extent back in the places where you're studying or where you're working. But by the end of the day, the whole aim of basic life support remains the same. So what will be the objectives that we'll be looking at today's webinar? We'll try and understand what adult basic life support is. Again, when I say adult basic life support is, we're not going to discuss CPR or basic life support in children today. Though it could be a bit similar, it's very different. So we are not going to look into that. Adult life support itself is a huge topic for us to cover in 1 hour. What else are we going to achieve today? We'll try and demonstrate basic awareness behind the knowledge regarding BLS. What is BLS? How should it be done? Why should there be a sequence of steps? Why we can't do the last step first and first step last? So if we know what we are doing, how we are achieving it, only then will you understand the importance of a sequence. Learn the structured approach and sequence of actions involved. So like I said, it has to be a structured approach. On what situations do you give BLS, basic life support? It already happens in a scene where there is a lot of chaos. So somebody is unconscious or something has happened. There's so much of chaos. There are so many people who are trying to give you ideas. There should be one procedure that's right, and that is the BLS. It should be structured. It cannot be chaotic. If it's chaotic, you're wasting time. And in an unconscious cardiac arrest patient, you cannot waste time. That's why, to understand that BLS is a structured approach, it will give you reassurance. It will calm you down. You know what you're doing. Next, we will move on to post-resuscitation care. What happens after the resuscitation? When should we stop? Or if it is successful, if it's not successful, what's the post-resuscitation care? And the very famous thing that we're talking about, the infamous thing, I would say, this COVID-19 scenario. Unfortunately, everything that we learn now should be somehow connected to the COVID-19 scenario. Is it different if there is a COVID positive patient, or is it different because we have COVID around? So we will hopefully touch at these points and move forward with our presentation. What is basic life support? Basic life support is the act of supporting a patient's breathing and circulation. So remember that what we are trying to achieve is breathing and circulation during a medical emergency until professional medical attention can be provided. So basic life support is only the start. You're not completely reverting the situation. You're only trying to keep the breathing and circulation active so that the body doesn't collapse, and so that before the medical help comes, you have done something. In short, basic life support is trying to keep someone alive until emergency medical service gets to the person. I hope I hope I'm not too fast. I hope I've explained what basic life support is. Remember two things: breathing, circulation. So you're trying to keep them alive. So what happens in a basic, basic life support scenario? There is a chain of survival links. Like I said, it is a structured procedure. So there is a chain of survival steps. When you put them together, you will maximize the survival from a cardiac arrest. So different things that you do in basic life support, when put together, will help in ways to revert a situation of cardiac arrest. The first link in the chain is immediate recognition of the emergency and calling for help. Immediate recognition of the emergency. So how do you know this is a basic life scenario? So that's the first thing that we need to do. How will we recognize that this is the minute where I have to act? Make sure that the victim and the bystanders are safe. So you will try, and you will not kneel down and start a basic life support unless you're sure that the bystanders and you are safe. Because when the ambulance crew comes or when help comes, they would want to save that one person who actually had an arrest, and not everybody there who collapsed because of improper actions. So for example, what do I mean by safe surrounding? If there is a flood, you won't stop in the flood to give basic life support, because that will cause loss of life for two people. If there is a fire, you won't be doing a basic life support act in the middle of the fire. So you will try to make sure that the victim, the bystanders, and the person who is giving the basic life support are safe. Once you make sure that this is all right, everybody is safe around, or you've taken away the immediate hazards, like the person has fallen in between two cupboards, you'll try to move the patient safely out of the from between the two cupboards. So just making sure that the scenario is safe, and then you will start with your actions of basic life support. What is the first step that you will do? Recognition. Like I said, we have to recognize what the scenario is. Check the victim for a response. Is he responding? How would you check the victim if he's responding? So you will shake his shoulders. Two things. One is gently. You will shake the shoulders gently. Why should you shake the shoulders gently? I mean, you're actually in a situation of chaos. Like I said, there is panic. There is every chance that you would, overrate your enthusiasm and actually shake the patient or resident too vigorously. That should not be done. Remember, shake the victim gently to check if he's responding. Why gently? Because if he's got a spinal injury, or if he's got other multiple fractures from the fall, you do not want to make that worse. Okay, you do not want to make that worse. And if the patient is even a little bit conscious, by shaking them vigorously, you don't want to make them into a panic state. That's why, how do you check if he's responding? How do you check for the victim's response? You will shake the shoulders of the victim very gently. The second thing is, you will ask loudly. You will ask loudly, because if the patient is going into a comatose state, if they are losing their consciousness, when I say speak loudly, don't shout at the person. You're trying to raise your voice just to make sure your voice is reaching the person. So you will ask the person loudly, are you all right? So you're shaking the shoulders gently and you're asking loudly, are you all right? Now, if he responds, what do you do if he responds? If he responds, at that point, you can shout out for help. Now, shouting out for help, if this happens on the road and you're on your own, you will shout for help. If this happens in the medical ward, where you have 20 beds and you are in the corridor, this happens in a medical ward, it would be helpful to shout for help, giving the location. For example, help needed in the corridor, or help needed in room 19. If you shout that out, the people who hear your voice will come rushing to room 19. Or if you have an emergency bell facility in that room, press the emergency bell so they automatically pick where the emergency is. So that's what we're going to do. If he responds, you will shout out loudly for help. turn the victim on his back so that he's lying on his back, and you will open the airway. How would you open the airway? You will open the airway. Just bear with me a minute, please. If the victim is responding and he's all right, place him in a comfortable position, that is on his back, and then make sure that there is no danger around, and try to find out what is wrong. If he's responding to you, hopefully he will tell you what's wrong. If he's not responding, like I said, if he's not responding, which is the second thing that could happen, either he responds, he can tell you what happened. If he does not respond, what do? You shout for help, and you turn the victim on his back and try to open his airway. You can open airway. This is the first line of action that you will use. That is the chin lift, head tilt maneuver. By doing this, you will open the airway. So what happens? Why do you think the airway is closed? Like I said, the two main things with BLS is trying to keep the breathing active and the circulation active. Breathing, that is airway and breathing. That is ABC, airway, breathing. What happens when a person collapses? There are two ways that there could be obstructions. One is the person's own tongue can roll over and obstruct the airway. The second thing is there could be something in the mouth that could be obstructing the airway. Or the third thing is, if there is a situation where there is vomiting or there is gastric regurgitation, the stomach contents could obstruct the airway. These are mostly the three, situations where the airway is obstructed. Let me repeat that again. The airway could be obstructed because the person's own tongue rolls and obstructs the airway, or there could be gastric contents that could come out and could be obstructing the airway, the stomach contents that could be obstructing the airway, or a broken tooth or things like that could be already or a person who is already eating something, there could be food in the mouth that could be obstructing the airway. So you have to first achieve opening the airway. How would you open the airway? Chin lift and head tilt position. Like you can see in this image, you will place the hand, or you will place one hand on the patient's forehead, and you'll push the forehead back. I hope you can see my cursor. You will push the forehead back and you will lift the chin up with the index finger and the middle finger, with the fingertips of your index finger and the middle finger. What happens in this situation? By doing that, you will help the tongue to roll away from the airway. The tongue will roll away from the airway. The airway will be open, and hopefully they can have some air circulation. The airway won't be obstructed anymore. So what we do is, remember the words, chin lift, head tilt maneuver. You will push the forehead with one hand. You will lift the chin, the bony part of the chin, the bony part of your chin, you will lift it up with fingertips of your index finger and your middle finger. By doing so, you're opening the airway. Now, what is jaw thrust? In situations where you suspect there is a spinal injury, where you suspect there is a head injury, you don't want to do chin lift because that could worsen the spinal injury. That could worsen the spinal injury. So you go for the jaw thrust situation, where you'll come and stand at the back of the patient, by the head of the patient. You'll place both your palms on the forehead, your fingertips running by the side of the jaw, and you will just gently lift the jaw up. By doing that way, you will not disturbing the spine a lot. For example, if you've actually seen visually, you have seen the patient fall, he hit his head first and then collapsed. That means there could be a chance that there is a spinal or head injury. Or if you can actively see bleeding coming from the back of the neck, from the back of the head, then you can suspect that there is a spinal or a head injury. In that situation, doing a chin lift, head tilt maneuver, things could worsen. So you go for the jaw thrust. In both the situation, what you're trying to do is you're trying to keep the airway open. So hopefully you have understood what we are doing in this chin lift and head tilt and jaw thrust scenario. When we find the patient unresponsive, the first step is you will shout for help, and the second step is you will open the airway, keep the airways open. Once you keep the airway open, if you have two people there to provide the BLS, you have shouted for help. So by now, hopefully somebody has come to give you a hand. So once somebody comes, the second person can go and ring for the ambulance, or if you're already in the medical ward, or if you're already in the hospital scenario, somebody will run and go and get you the crash cart, or they will bring the AED, automated defibrillator. This is very vital in helping survive a collapsed patient. So you've called for help, somebody has come up, and they will get you the crash cart, or they will bring more medical help. And if you are on the road and you are called for help, somebody should have by now rung the ambulance. What will you do if you are on your own? If you're on your own, you will ring the ambulance, you will place the phone on loudspeaker mode, and you will follow the instructions given by the ambulance crew. So hopefully now you've maintained an open airway by the head tilt chin lift maneuver. I hope you are with me till here. Now moving on with the open airway, what do? Keeping the airway open, look, listen, and feel for normal breathing. This is uniform anywhere around the world. Okay, though this is 3 words, you will do it all in one step. Look, listen, and feel for normal breathing. You will kneel down by the patient's head. You will place your cheek just above the patient's mouth. And when you're in this position, you're doing all your 3 steps. You're looking down at the patient's chest to see if the chest is moving up and down, if the abdomen is moving up and down, which would be the scenario in a normal breathing. So if the chest and the abdomen are moving evenly up and down, it means the person is breathing. You're listening for any breathing sounds. So when you put your cheek on the patient's mouth, just above the patient's mouth, you will be able to hear the breath sounds. How are the breath sounds? Is there a snoring? If it is a snoring, that means the tongue is rolled over the airway and the airway is obstructed. Is there a crowing? Is there a gurgling sound? What happens when there's a gurgling sound? When there is a gurgling sound, you know that the airway is obstructed with some secretions. It could be the gastric secretions, or if there is a stridor, that means the breathing is not normal. You know, a regular breathing, when you see a patient's breathing, or if you place your palm just in front of your mouth and you breathe in and out, that's the regular sound of a breathing. So by doing one step, you've already completed 2 sub-steps, which is you've looked at the chest and you're checking if the chest is moving at a normal rhythm. You have listened whether there is, what kind of breathing sound can you hear. And the third thing is you're feeling, all in the same step, you're feeling for the exhaled air against your cheek. So if you cannot feel an exhaled air against your cheek, it indicates there is some kind of obstruction, right? There should be an inspired air and an expired air, and the exhaled air, when it touches your cheek, you would feel the warm air. So if that doesn't happen, that means there is some obstruction. Look, listen, and feel, all done in one single step by kneeling by the patient's side, your cheek just above the patient's mouth. This should not be for more than 10 seconds, because when a person collapses, if the brain does not get oxygen in the first 3 minutes, by 3 minutes, then there could be a brain damage. So you cannot spend all day by the end of the side of the patient trying to assess just the breathing. So not more than 10 seconds. So by the end of the 10 seconds, if the person is breathing normally, we can move on with the next step, which is the recovery position. Now, if you have a doubt, is he breathing normally? Is he not breathing? You can still start the CPR. You know what I mean? If you are in doubt, you will think that the person is not breathing. You will not assume he is breathing. If you've actually seen the breathing, the chest movements, you can hear that the breathing sound is normal, and you can actually feel the exhaled air on your cheek very well. You'll put the patient in a recovery position. But if you cannot breathe, if you see that there is no breathing, or you're in doubt, you can assume that he's not breathing. It's better to start with the next step than sit on your knees and decide is he or is he not. We don't have time for confusion in a BLS scenario. Now, if he's breathing, you will turn him in a recovery position. What is a recovery position? So in a recovery position, you will turn the victim to the side, like in here. You're already kneeling by the resident. When you did the look, listen, and feel steps, you're already kneeling by the person. You will turn them in a recovery position, and this is only if the person is breathing. If he's not breathing, we have other set of steps to follow. So if he's breathing, we are not too bad. Okay, so you can put him on a recovery position. In a recovery position, the person is still unresponsive. He is breathing. You will kneel beside the patient. You'll take any glasses off because it could rub against the patient's face and cause further injury. You will take any glasses off, and you will place the arm nearest to you in a right angle. Can you see this? I'm showing with the arrow. You can place the arm of the patient nearest to you in a right angle with the palm facing up, with the palm open. And once that's done, you can bring the arm on the farther side, the other side, the opposite side of the patient, close to you, and tuck it behind the patient's cheek. So you will place the other arm, the opposite arm, turn it around, and you will place it behind under the patient's cheek. Once that is achieved, with your hand, you will grasp the person's knee. You will grasp the person's knee. Already when you have achieved this step with the arms, it will give the body, a tendency to roll. So it will be easy for you to grab the person's knee and roll them onto your side. Roll them onto your side. This is the recovery position. When you roll them onto your side, you will adjust the knee at right angle with the hip. Okay, you'll adjust the knee at right angle with the hip. Why do you do that? It will help the body to lie in that side lying position so that they don't roll back. Okay, and you can use this arm, the far arm of the patient, which is under the cheek, to help them achieve the head tilt position by where you're leaving the airway open. You can use the patient's own arm to help you with the head tilt position. Now, why do you use recovery position? So recovery position is used in a person, let me remind you again, recovery position is used in a person who is already breathing but still unconscious. By using the recovery position, it helps to open the airway. When you're doing this position, it already automatically helps to leave the airway open. Second thing is, if there is any obstruction like gastric contents in the person's mouth, it will drain out automatically by gravity. So that's how this recovery position will help you. By now, the ambulance should have come, or you have already sent for help with the ambulance. Let me, revise these few steps again with you guys. What's happening is you found a person unresponsive. You have made the surrounding safe. You've shouted out for help. You have knelt down by the patient. You have done your recognition and checked if he's breathing. Look, listen, and feel steps. You've checked if he's breathing. If he is breathing but still unresponsive, you've rolled him onto the recovery position. Why do you roll them on the recovery position? It will help to open the airway and will also help to drain out any oral secretions. Now, if he's not breathing, what do? Hopefully, somebody is gone for the ambulance. Somebody is going to call the ambulance, and somebody is bringing the AED. What is an AED? We will talk in the next few slides. AED is automated defibrillator. So that if that comes, that's brilliant in helping you with, a good recovery with your cardiac arrest. And you will start the chest compressions. You will start the chest compressions. What do you do with the chest compressions? You will kneel by the side of the victim. You will place the heel of one hand in the center of the victim's chest. What part of the victim's chest? Lower half of the sternum. The lower half of the sternum, in the center of the victim's chest. Heel of one hand on the center of the victim's chest. Heel of the second hand on the top of your first hand. And you will interlace your fingers. You will interlace your fingers. That will give you a good support to start your CPR. You will interlock the fingers and you will make sure that you're not doing it on the ribs. You will make sure that you're not doing it on the abdomen, because that can make further complications. First thing. Second thing, you are not achieving a good CPR by doing that. So you will place your hand, the heel of your one hand on the lower half of the sternum. You will place the second hand, heel of second hand on the top of the hand. Interlock your fingers. Your elbows should be straight and your shoulders should be on top of your hand. I will explain this again in a video, in a small video later. I know it must be difficult in an audio session, but visualize what I'm trying to tell you so that it'll help you. You interlaced your hands, you have brought yourself up with your shoulders right above your hand, and you will start the chest compressions. It should be nice and steady. What do you mean by steady? When you hear a heart sound, it goes lub dub, lub dub, lub dub. That's the steady. That's how you do a chest compressions. And you will, how deep the chest compressions can go? 5 to 6 centimeters or 2 inches. This will come with practice. This will come with practice. So steady chest compressions at 5 to 6 centimeters. And after each chest compression, you're not taking your hands off the chest. Your hands are still interlocked and still in contact with the patient's sternum. And you will, between each chest compression, you can see the chest recoil. Now, why do we do chest compressions? You should do 30 chest compressions. That is, in a minute, you should do it at a rate of 100 to 120 compressions in a minute. 30 chest compressions in a cycle, 2 rescue breaths. In a minute, that would add up to 100 to 120 chest compressions. Why do we do chest compressions? You are manually doing the work of the person's heart. You're trying to pump the heart so that the blood circulates out of the heart and is delivered to the brain. Like I said earlier, if the brain does not get oxygen, in 3 minutes time, the brain will have a damage. So when the heart is stopped, obviously there is no blood being circulated, there is no oxygen supply. So when you're pumping the chest, when you're giving chest compressions, you're doing the work of the heart. You're pumping the heart, you're pumping the blood circulating around to reach the brain. I hope you're clear with the chest compressions. Now, chest compressions with rescue breaths. After 30 chest compressions, the airway should have been opened with the second rescuer who's there to help you. You will pinch the nose of the patient. You will pinch the nose closed with your index finger and your thumb finger. Allow the mouth to open and you will seal the patient's mouth with your mouth and blow steadily. Give one breath in. You will blow into the patient's mouth. You will get up, you will look up and you will see the chest rise and fall, and then you will give the second rescue breath. These are called rescue breaths. So you will seal the patient's mouth with your mouth and then you will breathe in, lift your head up, you will see the chest rise and fall. That is what would have happened if the patient was normally breathing. You will see the chest rise and fall. You will go for a second rescue breath. Still maintaining the head at a head tilt, chin lift position. You'll do the second rescue breath and then you will continue with the chest compressions. You will continue the chest compressions at a ratio of 30:2. What is 30:2? 30:2 is 30 chest compressions and 2 rescue breaths. Now, why do you do rescue breaths? You're manually putting oxygen from your mouth. You're manually putting oxygen into the victim's lungs. And when that happens, the breathing will be replaced by your rescue breaths. Now, this is your explanation for combination of chest compressions and rescue breaths. 30 chest compressions, 2 rescue breaths. What is chest compressions only CPR? Here, we are not talking about rescue breaths. What happens is, if you're not able to give rescue breaths, in what situations are you not able to give rescue breaths? The patient has not opened his mouth. In spite of your head tilt, chin lift maneuver, the patient's mouth is not open. Or the patient has blood in his mouth. You cannot give rescue breaths. Or culturally, you don't feel comfortable to give rescue breaths. For example, it's a woman rescuer and the patient is a male. You don't feel like giving rescue breaths. In these scenarios, it is all right not to give rescue breaths, but chest compressions are vital. Start with chest compressions. If chest compressions are the only ones that are given, like I said, you should be giving it at a rate of 100 to 120 chest compressions. Stop after that, check that the victim is all right. If the victim has started breathing, put them in a recovery position. If they have not started breathing, continue the chest compressions till you get help. Now, what are the signs that the patient is regaining consciousness? He will be either coughing up, or he will be opening his eyes. He may be able to speak, or he will be able to move purposefully. That means he will restrict you. He will have a bit more power. He will restrict and move. These are the signs of regaining. These are the signs where you know that the patient you've had a successful CPR. Studies have shown that compressions only CPR are as effective as giving rescue breaths and CPR. So if you're unable to give rescue breaths, not end of the world. Continue with your chest compressions. Once you've moved on to the chest compressions, it should be done. Now, who can give BLS? Who can give chest compressions? All the qualified medical personnel, nurses, doctors, ambulance crew, anybody working within the hospital, or a qualified bystanders. Some people go ahead and do first aid and BLS training. These people can do chest compressions. What if you're on the road? You don't know what to do. You can still start chest compressions. You've heard of what chest compressions are. You've seen videos. You can still start chest compressions till you get an ambulance crew. What if you're not confident to start chest compressions? Call for the ambulance. Make sure that the patient is safe. These are some of the things you can do if you're not trained to do chest compressions. Now, mouth-to-mouth ventilation. If this is not possible in case there's blood or anything, you can still give mouth-to-nose ventilation. That is also acceptable. If the there's something else that mouth-to-mouth is mostly seen in a on the road or in a non-hospital scenario. You have something that can replace mouth-to-mouth rescue breaths in a hospital scenario, and this is very effective. It is called the BVM, or the bag valve mask. This bag valve mask should already be on your crash trolley. This is the mask. This is the bag, which will be having a small valve. It will be connected to the oxygen outlet. So it would be connected to the oxygen outlet. Like you can see in this picture, the head tilt, chin lift is still maintained. The chin is kept lifted up, head is at the tilted to the back. The mask is fit in a very good seal with no leakage of air, and you will press this bag once, so that first rescue breath is given. You will look at the chest rising and falling, and then you will go for the second rescue breaths. Now, when you are two rescuers, it's a very good idea to exchange the act. That is the rescue breaths and the CPR, because one person giving 100 100 chest compressions, it's very tiring. You will have two emergencies there. So to avoid that, it's always better to have two people to give you the exchange the role between yourselves. Another person should take over the CPR every 1 to 2 minutes to prevent fatigue. This will hopefully when you've shouted out for help, there are more than one people there to help you. So this is your rescue breaths. We've discussed chest compressions. We have discussed rescue breaths, mouth-to-mouth ventilation, bag, valve, mask ventilation as well. Now, I told you something about AED. So AED, it is a very sophisticated, easy to use medical device. It's called automatic external defibrillation. This is the device. It's brilliant. It's very brilliant. This is a small box that you can carry to the emergency situation. All you need to do is connect it to the patient. It does the rest of the work. It analyzes what is the heart's rhythm. It analyzes whether a shock is needed or not needed. If there is no necessity of the shock, it will not advise shock. It will only advise shock if it picks that there is a necessity for a shock. So what do you do? It provides electric shock, that is the defibrillation part of the heart. Your heart has electric conduction. So that's what's provided by this, AED. Every act has a scientific explanation. Your CPR, you're pumping the heart. Your rescue breath, you're giving oxygen to the person's lungs, which the person is not able to do by himself. AED, it gives the conduction, electric conduction to the heart. How do you connect the AED? When you open the box, you will have two pads. So you will you peel off the two pads. The pad already says where to put it, but I'll just explain where you put it. High right and low left. That's the way you put the pads. High right up here, and low left, just under the breastbone, low left. That's where you put your pads. So when you turn the AED on, the AED will give you advice. It's brilliant, like I said. It will give you advice. Place the pads on. High right, low left. Once you place the pads on, the AED will swiftly act. In the first 3 to 5 minutes, if you use an AED, there is a brilliant survival rate. There is every chance that the patient will survive. In a manual defibrillator, cardiac arrest, there are chances that the cardiac arrest could not be revived because you don't know when to give the shock. You will assume and you will just automatically give the shock. But in AED, the AED machine will assess the electric conductivity of the heart, and it will tell you when it's ready to give the shock. What else I can tell you about an AED? AED should not be used in a patient who has gone through a physical trauma where there are open wounds on the chest. Children under the age of 1, you do not use an AED. And obviously a victim who has a pulse. If the person who has you don't have to worry, the AED will tell you. So what does an AED do? By placing the pads on the high right and the low left, you're placing the pads in between the heart. The heart is placed between the pads like a sandwich. You're making a heart sandwich. So the heart is in between the pads. Electric shock is given, and if there is asymmetrical heart heart conductivity, it brings it back to the normal sinus rhythm. That's what the AED does. The AED will detect any irregular heart conductivity, and it will bring it back to the normal sinus rhythm. So that helps with the heart functioning back within its normal limits. When you connect the pads, if the shock is indicated, the AED will automatically give a shock. It will tell the shock is being delivered. If no shock is indicated, no, the person does not need a shock, you continue the CPR. While somebody is connecting the AED, you're already continuing with the CPR. You have not stopped the CPR. You only stop the CPR when the machine says shock being delivered. Now, when do you stop CPR? When do you stop this whole step of procedures? When a qualified help arrives, that is, an ambulance crew has come and they take over, or the victim has started to breathe, or you become too exhausted. You don't want two casualties. You have one casualty, that is plenty. So if you are becoming too exhausted, you are allowed to stop the CPR. Hopefully, if there are two rescuers, you will interchange and we can minimize the chances of being fatigued. That's the main thing about the BLS. A short flow chart to explain to you about the BLS. What happened first is you found somebody unresponsive and not breathing normally. You ask for help. Here we ring 999, which is the number for the ambulance. You ask for help or for an ambulance crew to come. You don't wait, you start with your 30 chest compressions. Once the 30 chest compressions are completing, you will keep the person's head tilted, chin lifted, 2 rescue breaths. Once the 2 rescue breaths finished, you will continue with the 30:2 cycle of the chest compressions. As soon as the AED is on the site, you will switch the AED on. You will follow the instructions. AED tells you what to do next. But once the shock is given, you continue with the CPR until somebody has come to help you. Now, let me quickly share with you a video which will explain to you what we talked so far.
Just a minute.
Oh, sorry, my bad. I think they will help you with the video. I hope I was not too fast. I hope I've made some sense. We have another 10 minutes, so we'll try. The video is only 4 minutes, so we'll try and rush through the rest of the things. Don't panic in the situation of what do you say, an emergency.
Excuse me, madam.
Yes, sure.
So audio is clear for you?
I can hear.
Yeah.
The video is ready to be played.
Okay, just a minute. Open and see.
We are trying to play the video. It's a 4-minute video. It will brief through all that we spoke just now. Shall I keep talking till the video is on?
We will allow the video to complete first.
We'll complete with the video first.
Are you okay? Are you okay? You, call 911. You, get an AED.
This is a scene that plays out over 1,000 times every day in the United States. If you see or find an adult or teen who has collapsed, they could be in cardiac arrest, and you need to act now. Assess for any signs of movement or normal breathing. If the person has slow, deep gasps, this is not the same as breathing. Call 911 or direct someone to call. Treat. Press hard and fast on the center of the chest. Place the heel of your dominant hand directly on the center of the chest and interlock the fingers of your other hand. Keep your arms straight and lean over the victim, using your body to compress the chest. Push down hard. You need to compress the chest at least 2 inches and push 2 times every second or 120 times per minute. Allow the chest to recoil completely with each compression. If the victim is on a soft surface, like a bed or a couch, move them to the ground before beginning compressions. You may have heard in the past that you must do mouth-to-mouth ventilations. Mouth-to-mouth is not needed for adults or teens and could be harmful. Perform chest compressions only. However, mouth-to-mouth is needed for young children and infants. While performing chest compressions, direct someone close by to get an AED. The AED, or automated external defibrillator, is the only thing that will shock the victim's heart back into normal function. When the AED arrives to the victim, Simply turn it on and follow the voice-guided instructions.
Unit OK. Stay calm. Check responsiveness. Call for help. Attach defib pads to patient's bare chest. Don't touch patient. Analyzing. Don't touch patient. Analyzing. Shock advised. Don't touch patient. Press flashing shock
When the
button.
video finishes, please tell me because I can't see the video.
Shock delivered. Start CPR.
The AED will only deliver a shock to someone who needs it, so do not be afraid to put it on anyone who is unconscious. Now that you know how to act, let's watch this again.
Are you okay? Are you okay? You. Call 911. You, get an AED.
Keep your arms straight and lean over the victim, using your body to compress the chest. Push down hard. You need to compress the chest at least 2 inches and push 2 times every second or 120 times per minute.
Unit OK. Stay calm. Check responsiveness. Call for help. Attach defib pads to patient's bare chest. Don't touch patient. Analyzing. Shock advised. Press flashing shock button. Shock delivered. Start CPR.
In many instances, an ambulance or other medical professional can be 5 to 10 minutes away or more. Continue chest compressions while rotating compressors every 2 minutes until help arrives, and continue to follow the instructions of the AED or 911 dispatcher. You be the hero. Teach your friends and family to act now.
Excuse me, ma'am.
Yeah,
Yeah, you can continue.
Hello. In this health sketch,
thank you so much.
about
So
which
hopefully we have finished with the video. Hopefully you've understood what happens. So what could the scenario be? It could be anywhere. A person could fall, collapse in a hospital setting, on the road, in a restaurant. Are you ready to give BLS? Are you ready to give basic life support?
you have to
You
remember
don't have to worry about keeping the person alive.
D.
If you start the first few steps, the ambulance crew or the medical help will be on its way and they will carry on forward. But like I said, the first 3 minutes are very vital. Just giving you a summary about what we've done so far. The basic essential components of a BLS is airway, breathing, circulation, rescue breaths, head tilt, chin lift position, recovery position, chest compressions, AED. Airway, clearing the airway allows air into the body. Breathing, providing rescue breaths, provides oxygen into the lung. Circulation, something has happened. Have we run out of time?
No. You can carry on, ma'am.
You can carry on. We have a time actually. No worry.
I think I've lost my screen. Just hold on for a second. From current slide. Resume slideshow. Yeah, coming to the circulation, chest compression. What does chest compression do? It pushes blood around the body so that oxygenated blood reaches the brain. Minimal brain damage. Defibrillation. What does defibrillation, automated external defibrillator, do? It tries to restart your heart. Applying rescue breaths and doing chest compressions is often referred to as CPR, which is the cardiopulmonary resuscitation. Coming to the famous or the infamous COVID-19. So what does COVID-19 change the situation? Does COVID-19 mean we shouldn't be giving CPR? there's a lot of debate around it, but we have to act fast. So luckily, institutions and all give their feedback, and we have a COVID-19 and BLS package as well. So what happens? Person has collapsed. What were the first steps? Look, listen, and feel. You can look, but do not listen or feel by placing, just bear with me a second. So just plugging the computer back on. So you can look to see what's happening, how the patient is: blue, pale, is he responding, is he breathing? But do not put your cheek on the patient, just above the patient's mouth, because there is airway exposure. So you do not place your cheek on the patient's mouth. If there is any doubt about whether the patient has got cardiac arrest or not, what would you do? You would just start chest compressions. If you have a doubt if he's breathing or not, you would start chest compressions. If you have a doubt whether the person is in a cardiac arrest or not, you have not confirmed, start the chest compressions. Make sure the ambulance is on its way. If the COVID-19 is suspected, if you think it has happened in a home scenario, God forbid, it has happened in a home scenario, you already know that the person has got COVID-19, or it has happened on a COVID ward where you know already that the person is having COVID-19. When you're calling for medical help, you will let them know that this person is COVID positive. Like if you're calling the ambulance, you will let them know that I am currently giving BLS to a COVID-19 person. So if you don't know that the person is COVID-19, in today's scenario, you would assume anybody you are providing CPR, anybody you do not know is COVID positive. So you will assume that. So to reduce the risk, you should place a small towel or a small piece of cloth on the patient's nose and mouth. Even if you do not give rescue breaths in COVID-19 scenario. So even if you're giving or not giving rescue breaths, you will place a cloth on the top of the nose and mouth of the person, and you will start compressions until the ambulance crew arrives, or until you get the AED, where you will start the defibrillation. If the rescuer has if I'm the rescuer and if I have a PPE available, my first priority, unfortunately, is not the patient, is not the victim, is me putting the PPE on. What I mean to say is, for example, if you're working on a COVID ward and in room 19 there is a cardiac arrest emergency, you will not run into the room like you would run before the COVID situation. And before the COVID situation, you will just hear the emergency bell, you'll run into the room. But in the COVID situation, you will first wear your PPE before you go into the room. That's what's different with COVID and the regular BLS. After performing the chest only compressions only CPR, no rescue breaths, compressions only CPR, all rescuers should wash their hands thoroughly with soap and water, alcohol-based gel, if soap and water facility is not available. They should also next go on to take the advice from hospital, ring a hospital and inform that you have provided CPR and you're not sure if that was a COVID or a COVID positive or COVID negative patient. They will tell you what to do. Here we go ahead with informing the NHS 111. That's the number we have for medical help. So we will let them know, this morning I had to give a CPR, BLS procedure to a person. I do not know if the person is COVID positive or not. So they will tell you what to do next. Maybe they will tell you whether you will need any screening. So that's what the COVID situation will be different when compared to the regular BLS. These are the references. Hope I have done justice to BLS at least a little bit. Hope I've given you a preview shot of what BLS is. It's very thrilling. This is the active part of your nursing professional. In the starting first few years, I was very anxious about BLS, but as you do it, as you go attend trainings, you will be more confident. What you need, being a good team leader in a BLS situation, or being a good active helper, will actually make a lot of difference to a positive BLS experience. I think that's all is what I've got to say. Do you have any questions to ask? Have we run out too much out of time?
Yes, Bexy ma'am. There are a few questions, especially from Swati Tripedi. She's
Okay.
been asking if the victim is having any kind of visible chest injury or open bleeding. Can we able to provide CPR?
You would actually, if the person is breathing, you put them in a recovery position. Like I said, in a traumatic chest, visible chest bleeding, it's advisable not to do CPR, and hopefully by then the ambulance crew would have come and they will take over from there.
Okay. So there is another question like, is there snoring can affect the cardiac arrest?
Snoring won't affect cardiac arrest. It will affect the ABC of a emergency situation. Airway, breathing, A and B will be affected. So if there is snoring, that means there is a chance that there is airway obstruction, either by the tongue or actual objects or anything like that. So snoring means there will be an affected airway and breathing. So if there is an affected airway and breathing, there is affected oxygenation supply to the brain, and it will affect the decline or the deteriorating situation of the patient. So snoring does indirectly affect the CPR. But like I said, the first step is to maintain the airway and then go to the CPR.
Right. And there is a general question, how to prevent cardiac arrest at night during sleep?
Oh, how do you prevent cardiac arrest? I hope we know the magic trick to do that.
Yeah.
Two things. Cardiac arrest can happen day or night.
Yeah, true.
You cannot prevent it. But if you're in a hospital scenario, you are lucky. You have monitors. You already know this patient has cardiac history, so I should be more vigilant in giving care. You already have the heart rates and blood pressure monitorings. So you know where you are going. If you have a poor vital sign recording, that means you should be more vigilant with that person.
All right.
Or sorry to interrupt. Or if you have given any heart-related medications, you know you have to keep an eye.
That's fine. Thank you very much about it. Participants, is there any other questions? Maybe we can have it as a last question before we wind up. If there
Just a thing, actually, I was asked what could be the complications of a CPR. There are clinically contraindicated. Let me first tell you contraindications. Contraindications. Can you give CPR or can you not? Clinically, you can give CPR. Any situation, you should give CPR. On the road, if something happens, give CPR. Legally, if somebody has a legal document, do not attempt CPR. You should not give CPR. In a hospital scenario, you would know if the patient is for CPR or not. So you will not give CPR if they have a red form which says do not attempt CPR. On the road, you do not know if they have a legal document in place. You can still give CPR. Samaritan law will protect you. These are the contraindications. You should give CPR if there are no legal things in place. What are the complications? That's what happens in our situations. In the hospitals, if you have to drag a patient out of the bed onto the floor, give CPR. There is every chance that there will be skeletal injuries like rib fractures. There will be every chance that there will be visceral injuries or gastrointestinal injuries. But what we say is, if it is an elderly patient, there would be already a plan in place. No, they cannot have rib fractures and they cannot have life damaging situations. So do not attempt CPR. That would be already in place. But if it's an active adult, for example me, I don't mind having rib fractures, but I would want to be alive, if you know what I mean. So please go ahead and give me CPR. I will heal my rib fractures, but I would rather be alive.
That's fine. And to add on a point, if the patient is hospitalized, the document will be written as DNR. Do not resuscitate. There will be a pre-advocacy will be there.
Yeah, I do not know how things are in India, but in UK it is DNA CPR. Now it's called a respect form. Rather than shouting out not for resuscitation, not for resuscitation, the more human way of saying is he's got a respect form.
All right. Okay. So I think looking at the time, it's almost time to rewind. We will leave it to our principal, Mrs. Sofana, for a thing. And thank you, Mrs. Bexy. I'll leave it to.
Thank you. Thanks, Lord. Thank you.
Thank you, Bexy. It was really informative, and you were very confident. And I could feel that you were speaking from your experience. I think that was more necessary for our audience also. And it was really, really nice to have you. And I'm really happy to see you doing well over there.
My pleasure, ma'am.
And to all the participants also, I say a word of thanks for coming over and attending, and looking forward for more participation in the coming webinars also. And thank you and have a good day.
Thank you again. Thanks a lot, ma'am.
And good day to all. Please find your feedback form on the link and you can fill up that. And MNR is proud about you, Mrs. Bexy. Thanks a lot.
Thank you so much. Thanks a lot. Thanks for giving me the opportunity. Thank you. Thank you.
5 minutes. Ending for all.